Good afternoon, ladies and gentlemen. This is Holly Lemaster, the Program Director of the Colorado MESA Initiative, and I would like to welcome you to today's webinar on clinical pearls and protocols. We'll cover a couple of housekeeping items before we get started. I'm sure you're all familiar with your GoToWebinar control panel, which is probably floating in the upper right part of your screen. This will allow you to control your experience during the webinar today. If you are unable to hear us, you won't hear me saying this, but you will have the option of using your telephone. And there is a phone number there that you can dial in and use the access code and the webinar ID that you see on the screen now that were also in the email that you were sent to confirm your participation today. If anyone is having trouble hearing us, please feel free to give that a try. And if you can hear me, please raise your hand. There's a little hand raising icon. Okay, great. See some hands coming up, so we know we're coming through. We will address questions and answers at the end, but you can type those in at any time during the session using the question box in your GoToWebinar control panel. I'd also like to remind you that we always post the archives of these webinars, and it will be on the website coloradomesa.org on Monday. You'll want to go to the classroom section and then look under the webinar archives to find it. So, Colorado MESA Initiative is Medicare Experts Senior Access, a grant-funded program that is all about helping primary care providers be more adept at coding and documentation for Medicare, helping you get paid fairly for the good work that you're doing, and feeling maybe a little more comfortable taking care of the senior patients. This is a collaboration with the Alzheimer's Association Colorado chapter and was founded by Dr. Donald Murphy, who's one of our speakers today. We're funded through generous grants from the Colorado Health Foundation, and we have supplemental funding from the Kaiser Permanente Foundation and from Caring for Colorado. So I'll introduce our speakers for today. First of all, Dr. Don Murphy is, as I mentioned, the founder of the Colorado MESA Initiative, graduate of Notre Dame and the University of Colorado. He did his geriatric fellowship at Harvard Medical School and started the Senior Care of Colorado practice back in 2001. He's been repeatedly voted one of the top docs in 5280 magazine by his peers and is a foremost expert in geriatric medicine. And we have two experts in geriatric medicine today. We also have Dr. Gregory Gahm. He's a medical director for multiple long-term care facilities and an associate clinical professor in the Department of Geriatrics at the University of Colorado. He is the president of the Colorado Medical Directors Association and a native of Colorado. He also holds an MPH in Medical Informatics and Administrative Medicine from Harvard. Welcome, doctors.
Thank you, Holly.
We are going to talk today about the MESA Pearls and Protocols. And many of you are familiar with this document. You probably have the first edition from 2010 if you have been at any of our live workshops. If you don't have a copy of that document, it's still available on our website. You can go and get the PDF version. You just log in and navigate over to the classroom, look for the downloads and links, and then go to Clinical Geriatric Care, and you'll see it there. We are busily working on the second edition and the update of the Pearls and Protocols, and that's what we really want to talk to you about today. And so I'll hand it over to you guys to talk a little bit about your process and how you're putting it all together and what you'd like folks to know about it.
Thanks, Holly. Let me just first say that I think that there is a significant difference, or several differences between 2010 and the one that will be coming out shortly. The key thing is that I asked my good friend and colleague, Greg, to really write these. And what we have now, what will be coming out, I think is an excellent summary of all of the key disease states that we've covered. Definitely has more substance than what we had back in 2010. That's partly by design, and these are going to have, I think, just the right amount of substance. We didn't want to present review articles, textbook articles on each of the disease states, but we wanted to give more of an update and hit on key points that any clinician could just go in and use as a quick reference. Secondly, I think we've reached a good balance between what I'll call evidence-based medicine. In my opinion, Greg is up on this as much as anyone in the field, the reason we leaned on you for this. And so the evidence-based medicine, what's out there in the literature, what's out there in terms of what's happening in the various facilities, the regulations, all those kind of movements we have to account for. But also it's balanced with what I would consider more of an empiric approach. That is, hey, we're not quite sure about this, this, or that. Let's think about trying this. So we hope that this set of guidelines presents a good balance between those things. And then, as we point out in the first guidelines, we're trying to account for all kinds of different things in these, not just the knowledge base about what's in the literature, but also how clinicians view risk, whether it's legal risk, risk of disease, how they're able to make decisions based on how closely they can follow up patients in nursing homes or assisted living, or all those kind of things. So these are the everyday things we clinicians have to take into account, and we're hoping that those issues are reflected in this set of guidelines too. Greg, you want to comment on the big job you accepted?
I didn't know what I was getting into, but actually I have to say I really enjoyed it, and it's nice to have the mix of evidence-based medicine, and most of the literature is not written for geriatric patients. Right. So it is nice to balance what really works, what's practical, with what does the evidence say, and even to come up with a middle ground that we don't know. Well, let's try it, but let's not try it forever.
Right. Exactly.
You know, let's try it for a period of time. If it doesn't work, let's get rid of it.
Yeah.
So.
Yeah.
Right. So I am working on editing this volume right now. It will be going to press very soon, and we're going to mail it out actually to all clinicians
who have attended one of our MESA workshops. So if you are not one of those people who has attended and would like a copy of it, please send me an email. My email address appears there on the slide, and we'll be happy to send one of those to you directly. We will also put the electronic version of the new edition up on the website, so you can download that. And we just want to encourage you to share this with everyone in your practice, anyone you might like to email the PDF to. We're putting this information out in the world, and we hope as many people as possible will use it. So today, Dr. Gahm and Dr. Murphy are going to talk about some of their favorite pearls. So let's jump right into that discussion, and we're going to start with anticoagulation.
Okay, I guess I'm going to take that one, and I like this quite frankly because of what's happened in the past few years. We have struggled with warfarin forever, chasing INRs, changing doses, people being non-compliant, changing doses when they get on different drugs and so forth. And I really think we're at a crossroads similar to when we switched from heparin to low molecular weight heparin, where we have 10A and thrombin inhibitors. There are now 3 of them approved for different indications. I will say that even since I wrote this part, I'm much less of a fan of Pradaxa, the thrombin inhibitor, than I was at the time. Eliquis has been approved. Xarelto is approved. Those are the 2 10A inhibitors. And I've landed, and this is just a personal thing, I've landed on Xarelto. It's once a day. Once you understand the dosing, it's pretty simple. It's one dose fits all. There are 3 different indications, different doses for each indication, and slight adjustments for folks that are over 75, under 132 pounds, or with kidney disease with a GFR less than 50. So there's a small adjustment down for those folks. But other than that, they not only don't change doses, there are no labs. And that's difficult for a lot of clinicians to get used to. There's got to be a lab I can check. I need to be reassured that it's working. And all I can tell you, it's oral Lovenox. An hour after you take it, they're therapeutic, even after the first dose. And 24 hours after they quit taking it, it's worn off. It's a wonderful drug. Of the 3 indications it's approved for, the post-hip, post-knee surgery, atrial fib, and PE-DVT, the one that I think it's just almost malpractice not to be using it for right now would be post-hip, post-knee. And that's just because the comparison was made to Lovenox, which is the standard out there. And it was anywhere from 3 to 10 times more effective at reducing the adverse outcomes, PE, DVT, and so forth. So I think based on just on clinical data, it's just much better. And then you start looking at the other things. It's about 1/5 to 1/10 the cost. It's oral instead of injected. It's once a day. It's same dose for everybody, and there are no labs. And finally, fewer drug-drug interactions than warfarin by a lot. And then, it's just a good choice. So really, that's all I'm going to say about anticoagulation.
And let me tell you what I like about this Pearl. One is the structure of it. You have all the categories like concomitant use of warfarin and aspirin, what to do when the INR is elevated. So it's very easy to follow. Two is I like that you actually just kind of went out there. You went out on a limb in terms of endorsing, so to speak, one particular one, and you make a good case for that. The thing I don't like about it is that it will need to be revised in 2 years, and we won't be around to do it. I'm assuming that this is one where.
Where are you planning to go? So?
Well, we'll be hanging around. We'll still be doing this. But this is a good example of a Pearl protocol, if you will, where
It's evolving.
it's evolving so rapidly. And this is, I think, excellent for right now. But 3 years from now, we're going to be going, what about? But that's life. So.
Okay. How about clysis?
I think that's mine too. And this is a simple one. If you haven't done it, jump to clysis early. Read this. It's just a few points. Easiest, simplest thing, and it scares people to death. And really, it's nothing more than taking a butterfly needle, attaching it to an IV bag and a catheter, and putting in, replenishing fluids subcutaneously. Nobody likes it because they haven't seen it. You do it with your cat. You do it with your dog. That's how they get fluids. You take them to the vet, but you're afraid to do it to people. And I'm here to tell you it's simple and it works. When I do this out in nursing homes, especially for little old ladies that have no veins, you can't get an IV in, they need fluids, they won't drink, it's wonderful. You get half a liter, a liter in, and all of a sudden their veins are open, you can put in an IV if you need it, or that may be all they need. The upside is you can do it to anybody. Demented folks, I do it in my dementia facilities, and all we do is put it in their upper back, under the skin, and they can't quite reach it to pull it out if they're confused. The only downside I can see is that it's a little bit slow. When you're running it in, it's 25, 30 cc's an hour. Takes a while. For those folks, you want to get fluid in quicker, put in 3 or 4. I had a lady about a month ago, we just put 4 in. We're getting about 120 cc's an hour in. 3 hours later, we got some fluid in, started an IV, gave her another liter, kept her out of the hospital, kept her from going in, saved her kidneys. It's just a cute little thing. There is literature about it. If anybody's interested, they can get in touch with me. I didn't make this up. But at any rate, that's what I have to say.
I love this one because although I've believed in this for the last 30 years and last used it that long ago, I've not seen it used here. And I think it's for the very same reason. It's not that I as a clinician didn't believe in it, but I was a little worried to push it in a facility where it seems like, oh my gosh, what are we doing here? It's great that you're actually doing it, seeing it. This is old-fashioned medicine that works, I think, incredibly well. And furthermore, I would emphasize the symbolism of giving fluids in those patients for whom we know it's more about symbolism, a hospice patient, for example. This is a good way to do it. So I think, yeah, we ought to be using this more. I will try and make that culture change the best I can, but I'm very encouraged that you're seeing it happen.
And I would just throw out, in facilities, the first time they do it, I offer, no matter who the attending is, I offer to do it. Don't have the nurse do it. Don't order it. I go in and do it, and I say, get everybody over here for about 15 minutes. We're going to show them. And all you do, you swab the skin, you've done the butterfly and set everything up ahead of time. You don't have to add any special drugs to it or anything. And you put it in under the skin. And half the nurses walk out in disgust and just say, really? I had to come over and that's all there is to it? Yeah, that's all there is to it. There are no secrets. It's not difficult.
Nothing to be afraid of.
Yeah.
So. Great. Okay, how about COPD?
Great.
Okay, that's me too. COPD, and I have to talk to the editor before she gets in the final edition because there's already a change.
Okay.
And that's that by this time next year, or certainly within 18 months, you probably won't be able to get meter dose inhalers because of the fluorocarbons that we're trying to take them out of the atmosphere, save the ozone, doing really good things. So all that stuff about spacers, we could probably just take out or modify. The new inhalers, it'll be the only way you can get atropine starting in July, and the others will follow suit in the next 6 months. It's more of a vapor or a mist, and it sort of clicks and turns. They're hard to put together the first time, which scares me a little bit about folks that are a little confused. But once you get it put together, you just sort of turn it half a turn, and it sends out a spray of vapor. It's well absorbed, easy to inhale. You don't use a spacer. So that was one thing to say. The main reason I wanted to talk about COPD is to bring out some simple things that we don't often think about, and that is that a lot of folks with heart failure, for instance, start wheezing, and every time we hear wheezing, we want to throw inhalers or albuterol or something at it, and not all wheezing is pulmonary. And in fact, in emphysema, most of it is not pulmonary. Emphysema is an anatomic, not a physiologic disease. It's destruction of lung tissue. Emphysematous patients can have reactive airway disease almost always after a specific trigger, and 99 times out of 100 it's a viral trigger. So there is a time for COPD patients where inhaled medications work. Steroids almost never work, by the way, in emphysema, and the GOLD guidelines, and GOLD is the Global Obstructive Lung Disease guidelines, come out every 2 or 3 years, recommend really strongly against any kind of chronic steroids in COPD. The exception is about 1 patient in 12 with chronic bronchitis that produces too much mucus will actually respond well, but it's not 9 in 12 or 10 in 12, it's 1 in 12. Steroids are indicated for short courses for COPD exacerbations. That's a fine thing to do, but get them off, 2 to 3 weeks and get them off. And then the last thing I want to say is something that we really do wrong a lot, and that's we give duplicate therapy to people. We put them on Spiriva and Atrovent. We put them on Advair, which has the steroid we don't need, but it's a long-acting beta agonist, and then we put them on routine albuterol to go with it. A lot of those folks, if they have atrial fib or they have heart failure, what you actually see with their emphysema is the wheezing gets better, and oftentimes it's because you gave them a beta agonist, you sped their heart right up, you improved their cardiac output for about 15 minutes, they felt better, and then you go over the Starling curve and it starts getting worse. The wheezing comes back, they reaccumulate the fluid, and you start thinking, well, we better give them some more. And actually, over time, you're just making things worse. The beta agonist will flog their heart and make things worse. Rethink using it at all in pure emphysema, but certainly don't give duplicate, don't give the long-acting beta agonist with the short-acting.
I will comment on one little paragraph. Actually, I'm going to read it, okay, because this illustrates where you were pushing me, the empiricist, so to speak, in a way that I didn't expect. So you have long-term treatment with the oral steroids is generally not recommended based on a large body of evidence showing significant side effects and none showing actual benefit in randomized trials. One exception might be in severely demented patients with advanced COPD who are unable to effectively utilize inhaled medications. Okay, you know, like you try it, monitor closely, see if it might be helping. If it's not, pull off. Okay.
Great. All right, let's move on to congestive heart failure.
Yes, I wanted to go over this one because to illustrate that there was a change from several changes, but the one key change from 2010 is this. Back then, I was making or we, the authors, were making an argument for not getting echoes. You didn't really need them. But Greg, you convinced me that we really should be in patients who have, let's say, greater than 6 months life expectancy for this reason. Now we have very good evidence that the use of beta blockers, ACEs, or ARBs for diastolic heart failure. For diastolic doesn't really help. I mean, right. it might in terms of controlling blood pressure, but in terms of using these things for the reasons we use them for systolic heart failure, we don't have the evidence in diastolic heart failure. And I think that's compelling enough evidence now, and with a greater move towards reducing unnecessary medications, then I think it does behoove us, even in patients in nursing homes, ALF, again, assuming that they're going to be with us for a while, yeah, to know what the echocardiogram shows so that we can simplify their medication regimen. Now, we're of course going to treat the underlying things that might be making the diastolic dysfunction worse, for example, worsening hypertension. But the old approach of, gosh, they have heart failure, let's see if we can ease them onto a beta blocker or an ACE inhibitor or whatever, we need to differentiate between diastolic and systolic. So that's just to show that we can be open-minded about these things.
Very important.
I agree.
Yeah.
And the only thing I'd add, the 6-month target is that in the data, in the literature, that's the time period for systolic heart failure, for ACE inhibitors, beta blockers, and or spironolactone to start having a beneficial effect.
Right.
So,
Well, one other thing about this, I think you're as emphatic, if not more emphatic, than I've been in the past about get rid of DIG. I mean,
there's not a place for it, really.
Okay.
Okay. How about use of psychotropic meds?
Oh, this is a good one, Greg. Just you start out and then
Yeah.
let's illustrate the great debate.
Yeah, I think if you start with antipsychotics, there are 18 really good randomized controlled studies now looking at antipsychotics versus placebo and so forth in demented folks. So really off-label indications. There are another couple dozen on things like PTSD, borderline personality, sort of other things. And the most fascinating thing is if you read the box warning, it really is true, and it's a summary of these 18 trials. You nearly double their mortality rate within 6 months, and the drugs are no better than the sugar pill. In the KDAD trial, it is true that Zyprexa and Risperdal, it took almost 6 months before they were discontinued for lack of efficacy, versus Seroquel and placebo, which were stopped by 9 weeks for lack of efficacy. But when they balanced, okay, it worked for an extra 3 months before you stopped because it didn't work, with the fact that family couldn't tell the difference, physicians couldn't tell the difference, and it nearly doubled their death rate. It's tough. So where do I land? I mean, if I were going purely with the data, I'd say just don't do it. But I don't. I'm out there practicing. I'm in dementia facilities. So what I tell people, use a simple formula. Define explicitly in writing before you start what it is you're trying to treat, what you're going to make better, what is the behavior, the symptom, whatever it is that's putting this patient or other patients at risk that you're going to try to fix with this drug. And then use the drug. And based on the half-life, go aggressively at it. If it's Seroquel, you pick my least favorite antipsychotic. But if you want to use Seroquel, use it at least 2 or 3 times a day and change it every 3 or 4 days. It's got a really short half-life. Every 3 or 4 days, make a new decision and push it until you either get whatever you want to fix better or until they have side effects. If it's Haldol or Risperdal, and I do like Haldol, it is my first choice, and that's a different discussion. But if you do like Haldol or Risperdal or want to do that, they're wonderful once-a-day drugs, 20 to 24-hour half-life. No reason to give them 2 or 3 times a day because that's the way they work. But you can make a change every week. Push the dose. Get it. Within 6 weeks, you will know because they'll be at steady state and you've upped their dose 3 or 4 times. You'll know if you're going to improve this behavior or not. And then you can wean them off and get rid of it if you didn't. If the literature is true, you'll find with all of these things, by the time you get through the trial, they work. I mean, it's not that they never work, but placebo works 16% of the time, and so do they. If they work and everybody's happy and they don't have side effects, keep going. All right, Don.
Okay. I agree with all of that with a few caveats. And I'll give you an illustration from a hospice patient we were dealing with yesterday. So this is a gentleman who has a lot of behaviors at night. The daughter, a nurse, asked that the facility put him on Depakote. Not an antipsychotic, but it's the same thing.
It's worse.
Well, okay, but literature doesn't show this. But the daughter is convinced that this will help. All right. And so he's been on Depakote, 125. The patient's still having some issues. Are they trying to redirect him? Yes, but. And so our answer was, let's try going to 250. It's against evidence-based, but it's reflecting the culture, the daughter's biases, and what we're going to do is give that a try. The facility is clearly looking for something. We're doing a little rope-a-dope here. I understand that. And if that little higher dose, even though it's not high at all, doesn't work, then we can start easing in the other direction. But this is taking all those factors into account. Had I not had the history that the daughter, a nurse, really wanted to try Depakote, we could have gone a different direction.
And I'll tell you, I don't completely disagree. You doubled the dose of his placebo.
Right.
And, so now you can pay $80 a month for a placebo.
Okay.
With its half-life, if you give it to him at nighttime, it's gone by morning, so he'll have none on board the next day. But if it fixes either in her mind or his, if it takes away those behaviors at that homeopathic dose, I think it's a fine choice.
Okay. All right. We will pause for an editorial here. And that Greg and I were through the CMDA, which Greg is head of now, Colorado Medical Directors Association, toying with the idea of resurrecting the use of placebos. We understand why we haven't in terms of the ethics around there. But the point is that, to be able to give our facilities something to try when they claim they've tried everything they can, probably not a bad way of approaching a number of different things, but we just haven't evolved to the point where we can do that freely.
You just did.
Well, okay, what I did here, though, I took advantage of the placebo-like effect.
Right.
I didn't actually use a placebo.
Right.
Okay.
Okay, should we move on to diabetes?
Diabetes. Okay, real quickly here, the reason I wanted to include this one is that although Greg has spelled out a lot of good, clear guidelines, we did put an emphasis here on getting rid of sliding scales. This is a measure we have used for the last 50, 60 years, has not been shown to be effective, creates a lot of unnecessary use of resources, this and that. There are exceptions when they're appropriate, but these are the exceptions. We ought not be using these nearly as much as we have been. So we're trying to move in that direction. The one other thing I'm going to say on this one, Greg, is that we comment on the use of metformin, and then when the GFR gets less than 60. I would argue that metformin has gotten a bad rap in geriatrics for way too long. And it has been because of this fear of lactic acidosis. I've seen that only once. And when you look at all the other things that could happen with the other medicines, including insulin, whatever, this is just a rare outcome. And that I think that this notion we had in the old days, never use metformin in people over 80. No, I don't agree with that. And in my opinion, it should be used more frequently in terms of overall safety and efficacy.
It's my favorite diabetes drug. It's the only diabetes drug to date in type 2 diabetics that's actually been shown to decrease morbidity, mortality, and secondary effects. The only one. And at least there's some argument that that may be because it also beneficially affects lipids. But yeah, I don't think it's hard and fast. But I do think if you're going to use it in somebody with given the litigious atmosphere we practice in, if you're going to use it in somebody with a GFR below 60, you should be explicit, upfront, have the discussion with the family. I think this is the best medication ongoing for their diabetes at this point. There is a marginally increased risk of a thing called lactic acidosis, which could be fatal. It's rare. It almost never happens. We can watch for it. Doesn't mean we can always catch it. Do you want to take that risk and make them commit? And when I do those sort of risk-benefit conversations with families or with patients, if they can have the conversation, I have them sign my note. I write all that out and I have them sign it.
And fair enough, and I would argue that if you have the time and in the setting where you can do that, great, but I can tell you that a lot of the clinicians out there, I think this could be overwhelming. And you could make a case for doing that kind of risk benefit in so many different things we do. And I know that there are some hot spots out there. There are.
But I would argue you don't get paid for doing depositions. Or for the week that you spend in court when you get sued.
No, but when our colleagues out there do, you and I'll go visit them. Okay?
There you go.
Okay.
All right.
That'll be comforting.
Yes.
Okay. We have got a little time for questions and answers
Here. And I see that we've got one question from Ken Davis, and he's asking, does Medicare cover DEXA scans for men over age 70? Does either of you know that, or is that something we need to look up?
That's a bit of a moving target. And you have to have a reason to do that in terms of initial screening. And the reason I say it's a moving target is that the guidelines are even changing on women. And so I can't tell you right now what that answer is.
Yeah, I think if you were going to do it to be safe, you'd want to say they've had previous fractures, or on an x-ray it shows that they're severely osteopenic. I don't think you'd want to be doing it as a routine scan.
Okay, any other questions? We'll give you just a few minutes to, in case you do have anything you'd like to ask Dr. Gahm or Dr. Murphy, go ahead and type it into the box there, and I'll do a few wrap-up reminders during that time. Want to let you know, first of all, that we have a lot of great information and resources for you on our website at coloradomesa.org. So please go there at your leisure, sign in to access the classroom section, and there you will find the archives of all of these webinars that we've done over the past months, video training videos, documents and links that are useful, including that Pearls and Protocols first edition that we referred to. So please use those resources and remind your colleagues to do as well. We have a number of workshops coming up. We're working primarily in the Loveland, Boulder, Fort Collins area. So you see those all on the screen there, and they're also on the homepage of our website. You can register for any of these workshops and get more details on our website. So we do hope you'll come out and join us in person if you're in one of these communities, and get to participate in the live workshop and hear the whole MESA curriculum. We are wrapping up our grant funding by the end of May, so we're moving into the final stretch here, doing our final workshops. So if you want to get in on the action, please come and see us at one of these locations. Also, just want to put in a quick plug for the rapid referral form. Remember to use these. This is a great resource for your practice. Any of your patients who have a diagnosis of Alzheimer's or dementia, or not even a diagnosis, just pre-diagnosis, maybe concerned about memory-related issues, you can use this form and fax it into the Alzheimer's Association. They will have someone get in touch with your patients or your family members, and they will be able to really help your practice in terms of the time that it takes to deal with the psychosocial issues that are related to these diagnoses that can be really difficult and very time-consuming for your practice. There's a rapid referral form on our website also under the downloads and links section. So if you go there to get one, just make sure that you pull out the correct one for your geographical region, and that'll get it in the right place. Our next webinar will be Friday, May 10th. That's not the first Friday of the month, but Dr. Murphy will be on vacation somewhere that first Friday, I believe. Yeah. So Friday, May 10th, same time as always, and we're going to be talking about transitional care management and those new codes that are available for you to use as of January. So you can sign up now at the website for that and join us on May 10th. Okay, that's it. I do not see any additional questions at this point, so we'd like to thank you, Dr. Murphy, thank you, Dr. Gahm, for your time today, and thanks everyone for participating. We'll see you on May 10th.